Good morning, everybody. Once again, thank you very much for the kind invitation. And, special thanks to Dr. Castin and Dr. Shifong. Today, my topic is lateral pelvic node dissection. I don't know how much you are interested in the lateral pelvic node dissection. I will just show what we have done and why we're doing lateral pelvic node dissection. No disclosures. As you know, the lateral pelvic nodes has been described long time ago by many, even Western surgeons and the Japanese surgeons at the same time. But their treatment for this same spread of the lymph nodes has been long time different. So lateral pelvic node dissection is not unanimously agreed. But the things are the mainstream of lymphatic flow from the rectum is upward, as we all know. But laterally, there are lymphatic spread, especially when the tumor is lower and advanced along mid-hemorrhoidal artery. So the incidence, the metastatic lateral pelvic node dissection, it depends on the advancement of the tumor and the enlargement of lateral pelvic nodes. The bigger lymph nodes, the higher rate of the metastasis. When you have the patient showing that more than 1 centimeter in short diameter, is almost 100% the positive. But you can reduce that one by radiation or remove surgically. Anyways, the incidence when the lateral pelvic node is small, invisible, up to 10 millimeters, the overall metastasis rate is 7.3%, according to previous RjColoMIS2024 trial. But if you look at the lymph node less than 5 millimeters, the metastasis rate goes down. It's like 5%. But the 5 millimeters up to 10 millimeters, metastasis rate it just goes up 21.4%. So the lymph node enlargement is an important key how to predict the metastasis. So this is the first question which was solved by the Japanese surgeons. They compared TME alone versus TME plus lateral pelvic node dissection. But unfortunately, they did not do any neoadjuvant treatment, chemoradiation. They didn't do. But with lateral pelvic node dissection or without lateral pelvic node dissection, the disease-free survival, the overall survival is exactly the same in both groups. Only they reduced the local recurrences from the 12% without lateral pelvic node dissection down to the 7% when they added the lateral pelvic node dissection. So what does this mean? Lateral pelvic node dissection is not very common event, and also is nothing contribute to overall survival. But definitely it contributes to lateral pelvic local recurrences. So surgery alone, like a Japanese style, lateral pelvic node dissection, let's show that 7.2% metastasis rate. So relapse-free survival, overall survival is the same as TME alone. Local recurrence can be reduced by lateral pelvic node dissection. So this is the policy of Japanese style, but we don't agree this. Why? So more than 90% of patients are overtreated. So 90%, we don't need lateral pelvic node dissection. So this is not accepted by any other countries besides the Japanese. So, which is better? Some studies, compared lateral pelvic node dissection and the chemoradiation. And they compared TME plus lateral pelvic node dissection in Japan and only CCRT in France. But notably, there are no differences, even lower local recurrences in chemoradiation group in France than the lateral pelvic node dissection group. Especially lateral local recurrences is far less in the CCRT group compared to lateral pelvic node dissection group. So this study concluded that lateral pelvic node dissection itself did not demonstrate any benefits over CCRT, but related with a higher complication rate. And another study also compared lateral pelvic node dissection without CCRT versus some result from the Dutch trial. Did CCRT plus TME versus TME alone. Both lateral pelvic node dissection and the CCRT can reduce local recurrences compared to TME alone group. So both modalities quite effectively controlled local recurrences, but not perfectly controlled by only one single approach. So the other question is, when we do CCRT, then we don't need lateral pelvic node dissection. That is the question. And this is the well-known studies who compared advanced rectal cancer, did CCRT, all the patients, and compared lateral pelvic node dissection versus no lateral pelvic node dissection. It's notably when the patient showed initially on MRI bigger than 7 millimeters enlargement of lateral pelvic nodes, even after chemoradiation, all the parameters, lateral local recurrences, and disease-free survival, and cancer-specific survival, lateral pelvic node dissection group is significantly better than TME alone after CCRT. This important study showed us the value of lateral pelvic node dissection even after chemoradiation. So when the patient showed enlargement of lateral pelvic node, so especially lateral local recurrences is very high when you do the CCRT alone. When you remove that one surgically, you can reduce lateral local recurrences. So quite similar result. We already published that one. Our policy about 10 years ago was we did CCRT. When the patients showed very good response, we do just TME alone. But now we changed. Regardless of the response to the chemoradiation, we added lateral pelvic node dissection. Why? When the previous our treatment is response good, and we did only TME. This is group 1. Why? What happened in group? We found that a lot of recurrences. 35% of patients we got recurrences eventually. Among these 11 recurrences, 7 only local recurrences. Among these 7 local recurrences, lateral recurrences 6. Among these 6 lateral recurrences, only lateral node recurrences are 5. So overall, half of local recurrences is only lateral recurrences in these patients. So we changed our policy regardless of the response to the CCRT. We have to remove that one, and then we can reduce the local recurrences. So what happened? When we changed our policy, our local recurrences come to 0. As you can see here, the overall survival is highest in these 3 groups. When we added chemoradiation plus lateral pelvic node dissection. So this is why we do lateral pelvic node dissection. And the selection is the key. When you do lateral pelvic node dissection for everybody, it can become an over-treatment. But when you select the patient very correctly with MRI, it's enlarged lymph node, you can reduce the local recurrences, you can improve the overall survival. So absolute cutoff value is like 5 millimeters, 7 millimeters. It's very difficult to say. Does lymph node matters? All we understand that lymph nodes matters, but even T1 cancers, when you have a depth more than 1,000 micrometers, you always recommend surgery. Because of the metastasis to the lymph node is around 0. Up to 20%. But the same rate, same incidence of metastatic lymph node to the lateral pelvic side wall when you have advanced low rectal cancer is even higher than these T1 cancers. But you still do not do the surgery. It's the irony. So this is we all agree to recommend the surgery for T1 cancers, but we don't agree the incidence is higher. We don't agree to lateral pelvic node dissection. This is, and somebody says lateral pelvic node is regional. Of course, if it's regional, you can remove. Then as TME or CME, whatever you think, because they think that some of them is systemic. So I will not do that. It is not true. Even systemic liver metastasis, we remove them. Lung metastasis, we remove them. So actually, regional systemic, it doesn't matter. It is not excuse not to do surgery. So absolutely, the root of lateral pelvic side wall is initially along mid-hemorrhoidal vessels, and go into the internal group, iliac group, and obturate, and the common iliac and para-aortic. Sequentially, it removed. And this is a study from the Japanese. They already showed that internal iliac lateral pelvic node metastasis showed quite similar oncologic outcome with the TME alone plus N2A metastasis lymph node. And when they have outside of internal iliac group, positive, the oncologic outcome is quite similar to N2B lymph node metastasis. However, these results are from the non-chemoradiated patient. So we started to compare in CCRT group, 670 16 patients. We compared 360 TME alone and 160 TME plus lateral pelvic node dissection. And we found that the disease-free survival, overall survival is quite similar. The overall lymph node metastasis in TME alone group is around 27%, and the overall lymph node metastasis is 44%, TME plus lateral pelvic node dissection. So you have, if the patient has lateral pelvic node enlargement, overall lymph node metastasis rate comes up. And the level of lymph nodes, zone 1 is perirectal lymph nodes in the TME alone group is 17% compared to 34% in the lateral pelvic node dissection group, and intermediate group of lymph node metastasis 8% in TME and 7% in lateral pelvic node dissection group. So et cetera, et cetera. And we compared, and we found that mean number of lateral pelvic nodes harvested in the lateral pelvic node dissection group is 8.5. And the metastasis rate to the lateral pelvic side wall is 32.5%. And among these patients, there are 10% of patients without mesorectal lymph node metastasis, but is positive in the lateral pelvic side wall. So we compared these lateral pelvic nodes positive group, and we found that this is quite similar to the Japanese group previously reported. The TMA plus zone 1 lymph node metastasis, which is a perirectal lymph node metastasis. When we look at it separately, in the lymph nodes metastasis to the internal iliac, the outcome is quite similar to the perirectal lymph node metastasis with the TME alone. When patient has obturate group positive, the outcomes are quite similar to the TME alone group is D2. D2 means zone 2 is the intermediate group. So both of lymph node metastasis, internal iliac obturate, can be considered as a regional, not the para-aortic, not the systemic. So the level of lymphatic spread is more important than the direction of the spread of the lymph node. Whatever is go up, go down, go laterally, it is not important. The important thing is how far the metastasis already spread. When it's spread to the internal iliac, it is quite similar to pericolic lymph node metastasis. And even go down, it's like inguinal, it's the same. It's a lesional when the tumor is very, very low. And it's go further and further as obturate and common iliac, it can become systemic. So the proximity to the original tumor is more important than the direction of the lymph node spread. So concluded, we did the lateral pelvic node metastasis did not compromise survival when compared to the TME alone group, and also metastasis lateral pelvic node may be the regional, not the systemic. So the another question is bilateral or unilateral. So Japanese did the bilateral, most of the cases. We did 88 cases bilaterally, so 100 cases right, and 130 cases in left side. But we found that very low contralateral recurrences is less than 2%. When we did right side lateral pelvic node dissection, because MRI showed only right side, and then we removed that one. Less than 1% can recur on the other side, left side. So our the prediction is quite precise and accurate. So we don't need to the contralateral dissection because we have a high resolution of the MRI. We can predict metastasis. So prophylactic bilateral or contralateral dissection is not needed. So far, why we do lateral pelvic node dissection? Because considerable number of advanced the low rectal cancer patients have metastasis to the lateral pelvic side wall. And TME alone and also chemoradiation alone cannot eradicate lateral pelvic node metastasis. So we need the combination of chemoradiation plus lateral pelvic node dissection with selection based on the high resolution of MRI. So selective lateral pelvic node dissection can be the answer and the option. But why you not doing lateral pelvic node dissection? Because it's just difficult. We worry about the complications. I never taught. My professor cannot do that. So we don't know how to do that. So the center of the region is fear. We have a fear to do something. But if you do, if you know how to deal with this, you can do that without complication. It's not difficult at all. So we developed three things. Number one is standardization. Number two is fluorescence plus 3D reconstruction. And we standardized our technique. We divided into two groups of the lateral pelvic sidewall lymph node groups, which is internal ilia and obturate, based on anatomical fascial anatomy. And this is how we do. You know, it's not working. It doesn't matter. It's not important. So injected ICG 3 to 5 hours before the surgery, and we reconstructed the possible index lymph nodes by 3D reconstruction, and we can navigate that lymph node during the surgery. And also we can, the real time, to navigate the positive lymph node, possible potential lymph node, and then we mark it and send it to the pathology examination. So this is how we do. So what we found is the index lymph node is mostly internal iliac group. It's not the obturate group. Obturate group is 1/3. And the malignant potential of this index lymph node is 40% positive. And among these index lymph nodes, the index lymph node only positive in 78%. But the sum of 22% of the patient index lymph node positive and unnoticed by previous MRI showed positive as well. And internal iliac group is the highest, most common area to have a metastasis. All these efforts can increase number of harvested lymph nodes.
And in
So
conclusion, dual image guided
guidance,
lymph node navigation for index
is quite effective. And this is our final results. We compared laparoscopic versus robotic. And we found that urinary complications far less in the robotic, and disease-free survival is higher in robotic group compared to the laparoscopy lateral pelvic node dissection group, and overall survival is also higher. So cancer-specific survival is higher. So the reason why we do lateral pelvic node dissection, without lateral pelvic node dissection, even after chemoradiation, you will have a very considerable number of recurrences. And when you decided to do lateral pelvic node dissection, I recommend the robotic approach is better than the laparoscopic surgery. So lateral pelvic node metastasis cannot be exaggerated or cannot be ignored. So we can accept the both modality of CCRT and lateral pelvic node dissection. And this is our upcoming event. Please mark your calendar, and I'm looking forward to have all of you in Daegu. Thank you very much.
Thank you, Professor. Very comprehensive presentation in short period. Thank you so much.
Thank you.
Excuse me, first. Can some question from Mina, please? Professor, small question, please. Mina. Because.
Thank you for your excellent presentation. I have two questions. We already know you can do a very excellent, perfect TME. And then, will you suggest TME alone when there is no positive lymph node metastasis by MRI?
Of course, my approach is only based on MRI. So without lateral pelvic node enlargement, we should not do that. Because when you do that, it's just exactly the same as Japanese do. It can be an over-treatment.
So that's not against the basic principle from European or American guideline.
I cannot understand.
I mean, for stage 2 or stage 3 rectal cancer, radiation is suggested by their guideline. But you will not do that.
We do.
But without pelvic lymph node suspicious metastasis, you do the TME alone without chemoradiation.
She
No,
means
we
maybe,
do.
right?
We do chemoradiation, but we don't do the lateral pelvic node dissection.
But my question is, since you do the complete TME,
Yeah.
do you think the chemoradiation is benefit for locally advanced tumor without?
Absolutely, absolutely. There are a bunch of evidences. Chemoradiation reduced local recurrences. Even it's nothing to do with your surgical skill. You cannot see the tumor cells. You have to do CCRT for the advanced rectal cancers.
Okay, but from Japanese guideline, they do not do that.
That's a Japanese guideline.
Okay. And my second question is, from your data, your laparoscope survival is worse, but even on them. So what's your opinion for that?
So my opinion is I don't know why, but the truth is I got the better results. I can explain, if I can explain, because the robotic is more recent approaches, and maybe we improved a little bit more skills, and also robot manipulate tissues more gently than the laparoscopy. So we can explain, but the answer is I don't know. But the truth is better results in the robotic group.
Thank you.
Thank
Yes,
you.
Thank you, Professor.
There is one more question.
Is
from
there
the floor.
one question?
One question from the floor, please.
Sorry.
Excuse me, Professor. After the preoperative CCRT, the MRI is still show the lymph node, not only the iliac group, but including external iliac vein and artery. Do you recommend to going on lateral node dissection?
Oh, yeah, of course, of course, of course.
Even
Whatever.
your data show that it look like a distant node, not the local node in the external iliac or the external iliac artery.
You know, theoretically, external iliac node can go to inguinal first, inguinal lymph node first, and then go to the femoral artery and vein, go into the external iliac. So when the tumor is above the mid-rectum or the upper rectum, the possibility is very low. And so you have to think about that. How this can travel along the external iliac, because there is no road. Sometimes there is a small road. So you have to weigh the possibility of this is a real metastasis or not. But when you have very round-shaped mixed signals, when you very strongly suspect that is metastasis lymph node, wherever it is, you have to remove it.
Thank you.
One more question from the floor, please.
Morning, Prof. Thank you for the excellent lecture. I'm Nora, colorectal surgeon from Malaysia. I've got a question. For patients who've done, say, low anterior resection, and then 2 years later they came back with one large lymph node in the lateral pelvic lymph node group, what would you do to these patients? Do you subject them to repeat surgery or do you send them to your oncologist? Oncologist for chemo?
You done the chemo radiation before,
Yes.
and then we'll do surgery. We
Yes.
call it the salvage lateral pelvic node dissection. Higher probability, more higher probability than just initial lateral pelvic node enlargement. If after surgery, you have new enlarged lymph node, it's almost always metastatic. So when you done the chemoradiation before, the surgery, directly we recommend the surgery. When you didn't do the chemoradiation first, and then surgery.
So patient has gone for CCRT, followed by surgery, and then was cleared. During surveillance, 2 years after,
Yes, and then surgery.
surgery again.
Surgery, yes.
Yes, thank you for
Thank you.
many questions. Please.